The following podcast is part of a certified educational activity titled Choices, Changes, and Global Perspectives in CLL Care, Real-World Insights and New Evidence on Finite Therapy with Targeted Agents. Access the entire activity and complete the post-test at peerview.com/WBT860. Downloadable slides and practice aids are also available.
Welcome everyone, I'm Lidia Scarfò from Università Vita Salute San Raffaele in Milano. Welcome to Choices, Changes and Global Perspectives in CLL Care. I'm very pleased to welcome my colleague Dr. Nicole Lamanna from Columbia University Medical Center in New York to this discussion. During this program, Nicole and I will look at the status of time-limited therapy with targeted agents in CLL and discuss how we can apply new evidence for fixed duration and MRD-guided treatment in CLL. We will also share selected results from an ongoing global survey designed to illustrate how clinicians are adapting treatment based on new developments with time-limited therapy. Let's begin. During this presentation, we will learn that guidelines are changing, and many guidelines in Europe and in the US are now recommending time-limited treatment with BTK inhibitor and BCL2 inhibitor combination. Growing evidence supports MRD-guided treatment with BTK inhibitor and BCL2 inhibitor doublets, triplets in high-risk CLL. Strategies were identified to ensure safety while maximizing efficacy and convenience of finite therapy and are now available to use in the clinic. In the treatment decision, we have to take into account several factors including functional status, high-risk factors, symptom burden, and patient preference. And these are all relevant when deciding on time-limited versus continuous treatment. Let's start by briefly mentioning the targeted agents we are currently available in the United States and in Europe. You see, we have 3 covalent BTK inhibitor approved, ibrutinib, acalabrutinib, and zanubrutinib. And recently in Europe, the combination of acalabrutinib plus venetoclax with or without obinutuzumab was approved in treatment-naive CLL. We have now available both in US and Europe a non-covalent BTK inhibitor, pirtobrutinib, that is approved for patients with CLL previously exposed to a covalent BTK inhibitor, and the only BCL2 inhibitor currently approved both in US and Europe is venetoclax. Starting from the NCCN guideline, you can see that here mainly 2 subgroups of patients were identified. Those without 17p aberration, either 17p deletion and or TP53 mutations, and those patients are suitable candidates for BCL2 inhibitor-containing regimens based on the administration of venetoclax plus obinutuzumab, or on the use of acalabrutinib plus venetoclax with or without obinutuzumab. Needless to say, in all subgroup of patients, we can use covalent BTK inhibitors as continuous regimens, including acalabrutinib with or without obinutuzumab or zanubrutinib. For patients carrying TP53 aberrations, on one side we can consider nowadays BCL2 inhibitor-containing regimen, either administered as fixed duration like venetoclax plus obinutuzumab, or the combination of venetoclax plus acalabrutinib plus obinutuzumab following an MRD-guided approach, or the combination of zanubrutinib and venetoclax, again based on the MRD-guided approach. Covalent BTK inhibitors as continuous regimen have shown efficacy and long-term disease control also in this subgroup of patients. If we move to the European guidelines, the ESMO EHA guidelines were actually published in 2024 and are currently being updated but not yet published. The treatment decision is based on one side on the biomarker profile, so we have mainly 3 subgroups: patients carrying TP53 aberrations that are good candidates for continuous BTK inhibitor treatment, and patients with mutated immunoglobulin genes who, regardless of fitness status, should be considered suitable candidates for the combination of venetoclax plus obinutuzumab. For patients carrying unmutated immunoglobulin genes but without TP53 aberrations, we have different choices based on the performance and the fitness status. So fit, younger patients are generally undergoing treatment with the combination of ibrutinib plus venetoclax, while patients who are unfit or elderly are suitable candidates for the combination of venetoclax plus obinutuzumab. Considering that recently in Europe we acquired also the option of using acalabrutinib plus venetoclax with or without obinutuzumab, you can see here the Oncopedia guidelines that are the German guidelines recently updated. And again, you see that in patients without TP53 aberrations with unmutated immunoglobulin genes, the possibility of administering acalabrutinib plus venetoclax with or without obinutuzumab was recently added, and this applies also actually to patients with mutated immunoglobulin genes. This combination is also considered as potential treatment options in patients carrying TP53 aberrations and or complex karyotypes. We would like to discuss today together the results of our global survey, and in particular, focusing on the factors taken into consideration when discussing the choice between time-limited and continuous therapy for CLL. And here you see that among the factors we listed as potentially relevant, the genetic profile, the treatment logistics, the safety consideration, and the patient preferences, almost 70% of respondents are including all these factors while counseling the best treatment strategies in first-line patients with CLL. And in those who select some specific factors in the discussion, generally the genetic profile, including genetic and molecular characterization in order to identify high-risk patients, as well as safety consideration and logistics, are the most relevant factors that are generally taken into consideration. Nicole, what do you think about this? How do you define the best suitable choice in your patients? Are you taking into account all these factors?
Yeah, I mean, I think it's telling us how increasingly complex it is when we're picking treatment options for our patients. And I absolutely do consider all of these features, their genetic profile, the treatment logistics, depending upon where they're coming from, safety and patient preferences. So I do integrate multiple factors when we discuss the treatments with our patients, but it just tells you how increasingly complex it's getting given the multiple excellent treatment choices that we have for our patients. So I'm not surprised to see this kind of data.
I totally agree, and I just say that sometimes it's a very difficult discussion when you have to explain so many treatment choices, but of course we are very happy to have such a possibility. And focusing more on some patient clinical scenarios, I would like to discuss with you the management of this 68-year-old man with treatment-naive CLL. The biomarker profile showed the presence of unmutated immunoglobulin genes and trisomy 12, but no TP53 aberration. In terms of comorbidities, he was diagnosed with hypertension that is well controlled and mild renal impairment. He wishes to achieve the deepest possible remission upon treatment initiation, but he also values a lot time of therapy. So considering the different treatment options we have available, you see here what the respondents chose. Would you agree with the majority? Would you have a different approach, Nicole?
Yeah, the patient expresses an interest in time off therapy. So I think that obviously the choices between venetoclax and obinutuzumab versus a BTK inhibitor and venetoclax are both viable choices for this patient. There isn't something that stands out that he couldn't get either of those approaches. You know, we know that he's unmutated and there might be a slightly shorter PFS, in the unmutated folks, but recent data shows that both fixed durations, at least with the ibrutinib combination, seems to be fairly similar, whether it's venetoclax, obinutuzumab, or ibrutinib venetoclax, the PFS for unmutated seem reassuringly similar. So I think you can either of those approaches, depending upon logistics, are okay. You can see that in this choice here, there's more favor. You can see that some folks are choosing the newer second generation BTK inhibitors with acalabrutinib with venetoclax as the combination. And so I think that in the US, at least, we would do more probably the second generation BTK inhibitors compared to ibrutinib combinations. But I think that both these fixed durations are certainly applicable to this patient.
Yeah, I totally agree. And I just say probably in Europe we have more experience with the combination of ibrutinib plus venetoclax because it was approved a couple of years ago. But as you mentioned, probably here the key point is that we want to achieve the deepest response, but also allow the patient to take some treatment holiday as he expressed this priority. So switching to a different case, a 72-year-old patient, again with a diagnosis of symptomatic CLL that requires treatment. And the reason for starting treatment is mainly related with the presence of bulky lymph nodes. And this time, the biomarker profile showed the presence of unmutated immunoglobulin genes, but the CLL cells are also carrying 17p deletion, so TP53 is wild type. And the patient is willing to undergo an aggressive treatment and is basically relying to his physician in order to decide the best treatment option. And again, Nicole, here you see the results of our survey, and there were different options available, fixed duration and MRD guided, as well as continuous treatment. What's your opinion on these options?
Yeah, no, this is complicated. I mean, obviously, the longest data that we have, of course, is with chronic continuous therapy. In at least in terms of the patients with deletion 17p, tend to have the longest PFS with chronic continuous. But certainly, now we have emerging data regarding MRD guided approaches with venetoclax and a BTK inhibitor, and so. I'm certainly more willing and open to consider doing a more time-limited approach depending upon some of the newer data that we have with MRD-guided approaches. I think the conventional fixed durations of, a venetoclax and BTK inhibitor or venetoclax or obinutuzumab, where it's either 12 months or 15 months if they're doing an oral combination for higher risk patients, to me seem a little short. So, I would choose in my practice, either a continuous therapy for the 17p or an MRD guided approach, given some of the current data that we have. That would be my preference, depending upon also the patient preference too.
That's, a great summary, and I totally agree with your perspective. Unfortunately, in Europe, we cannot tailor treatment duration based on the MRD status yet, but that would be very valuable, as you mentioned, especially in this subgroup of high-risk patients. So, trying to summarize the multiple factors involved in the treatment decision between time-limited and continuous therapy. Here you see on one side, we should definitely consider the disease profile, the TP53 aberration status, the immunoglobulin genes mutation status, the cytogenetics, the reason for progression and the tumor burden, and the depth of response we want to achieve. But on the other side, we should also consider the specific profile of each drug in terms of toxicity, logistics, requirement of monitoring, risk of long-term adverse event and drug-drug interaction, as well as the patient profile, including the comorbidity burden, the age, the organ function. The preferences of our patients are becoming extremely relevant, and the possibility of adherence to the treatment administered. So on one side, I say that especially from the European perspective, we favor time-limited regimens in the overwhelming majority of patients with CLL requiring first-line treatment. I just say probably the data are still limited and the jury is still out in terms of very high-risk disease, like patients carrying TP53 aberrations. And in the next future, it would be of great value to tailor treatment duration based on the MRD assessment. So now I would like to leave to Nicole the opportunity to present the recent evidence for finite therapy with fixed duration regimens.
Thank you, Lydia. So we'll now talk a little bit about targeted but fixed duration MRD guided options in some of the recent data. This is the CLL 17 data, which is nice to have a more modern randomized trial that had venetoclax, obinutuzumab, venetoclax, or ibrutinib. So you can see here the lack of chemoimmunotherapy. So we're happy to see that in this trial. And you know what's nice about this study, although the maybe the follow-up is a little short, but you could see here that the PFS at 3 years is approximately very similar between time-limited approaches versus chronic continuous therapy. And so again, I think this is nice and reassuring for people to have this data where they can sort of look at sort of the modern approaches of how we take care of our CLL patients and see that there's very similar outcomes across the board versus time-limited versus chronic continuous. I think maybe the only exception we can talk about, and we'll see with longer follow-up, has to do with our higher risk patients, our TP53 patients, where you could see it's still maybe, again, early on, but you could see maybe favoring chronic continuous therapy with ibrutinib here compared to our time-limited approaches. When you look at safety with regards to these more modern regimens, you can see that there's a little bit more neutropenia that we see with venetoclax, obinutuzumab combination, or the combination therapies, even a little bit more with venetoclax and ibrutinib compared to chronic continuous therapy with regards to neutropenia. Obviously, with the addition of ibrutinib, whether it be venetoclax, ibrutinib, or ibrutinib chronic continuous therapy, you have more cardiac issues compared to venetoclax, obinutuzumab, which we would expect from the BTK inhibitors. And then switching over to the Amplify data. So this is also a phase 3 study, but it looked at acalabrutinib venetoclax plus or minus obinutuzumab versus chemoimmunotherapy. And keep in mind that this is in the treatment-naive setting, but did not include patients with high-risk disease. So there were no 17P or P53 patients because of the chemoimmunotherapy arm. And you can see here that the PFS favors the acalabrutinib venetoclax arms compared to chemoimmunotherapy. There also is a breakdown that you can see based on their IGHV subgroups. And again, mutated patients are doing very well, of course, with the time-limited approaches and favoring, again, more of the acalabrutinib venetoclax arms. There's a little bit of a benefit with the triplet for acalabrutinib venetoclax obinutuzumab in the unmutated compared to the doublet, the acalabrutinib venetoclax containing regimens. And perhaps, again, needing to see longer time period, you can see a little bit of a split with the triplet versus the doublet here. And again, we'll need to wait longer follow-up on this, but you can see here that, again, another data set that sort of points us away to moving away from chemoimmunotherapy, but also gives us a little gleam about the difference between acalabrutinib venetoclax and then plus or minus obinutuzumab. And so we could think more about how to use a triplet, but again, mindful that there were no high-risk patients in this data set. There's more neutropenia with the arms that obviously had the anti-CD20 monoclonal antibodies, whether that be with AVO or FCR-VR. You can see obviously in the patients who are not too much more, but you could see a little bit more, perhaps AFib with the AVO arms, although not terribly different, I think, from AV or chemoimmunotherapy, maybe a little bit more hypertension with the acalabrutinib containing arms. But I think on par, there's no new safety signals from this data set that we can see. And keep in mind, for these, usually there's a lead-in with the BTK inhibitor before they started the venetoclax. That's sort of more standard practice that we're doing when we're combining the BTK inhibitors plus venetoclax-based therapy, that you start in with a lead-in with the BTK inhibitor for 2 to 3 cycles, and then you can add in the venetoclax. And then this is, definitely translatable to an outpatient type of a regimen. I'm going to give this back to Lydia to talk about the MRD guided approaches that we're seeing with some of the new data that's been presented recently.
So thank you so much, Nicole, for this very comprehensive overview. Now, if we move to the MRD-guided treatment, of course, we cannot avoid discussing the FLAIR study, that is the UK multi-center study enrolling patients with treatment-naive CLL and administering the combination of ibrutinib plus venetoclax for a duration of time that depends on the time required to achieve undetectable MRD status. So the treatment duration could span from 2 years, the minimum duration of treatment, up to 6 years. And the MRD status was confirmed sequentially in the peripheral blood and then in the bone marrow. And they actually proved that the achievement of undetectable MRD5 in peripheral blood is correlating with ibrutinib plus venetoclax with undetectable MRD4 in the bone marrow. On the other side, as mentioned, we had the design of the ABO trial, where patients received the combination of acalabrutinib, venetoclax, and obinutuzumab, and the treatment duration was again tailored based on the achievement of the undetectable MRD during treatment. So the treatment could be discontinued at cycle 16, so after 15 cycle of treatment, if the patient achieved early undetectable MRD status, or continue basically for up to 2 years. And here you see the impressive progression-free survival and overall survival curves from the FLAIR study, where the administration of ibrutinib plus venetoclax proved to be superior if administered in an MRD-guided way to ibrutinib single agent as continuous treatment and FCR treatment. And this translates in an overall survival improvement. That is something very impressive, I'd say, in this subgroup of patients. When the triplet acalabrutinib, venetoclax plus obinutuzumab was administered in patients with high-risk features, again, the 4-year progression-free survival in patients with TP53 aberration achieved a value of 70%, with an 88% 4-year overall survival. And again, the majority of patients, regardless of the TP53 aberration status, achieved deep responses with this triplet combination. So this was the, let's say, the underlying evidence for designing a MRD-guided study, and the next generation of MRD-guided study, of course, will include the MAGIC trial, where patients were randomized 1-to-1 to receiving the combination of acalabrutinib plus venetoclax or venetoclax plus obinutuzumab, again in first line. But the great novelty of this approach is that the duration of treatment is tailored based on the MRD status. So the treatment duration could go up to 24 months based on the time needed to achieve the deep responses. And the results also of the SEQUOIA-RMD trial were partially presented. They are based on the administration of zanubrutinib plus venetoclax. Initially, the RMD cohort included patients with high-risk disease, so they have very stringent criteria before discontinuing treatment. Patients should achieve complete response and have confirmed peripheral blood and bone marrow undetectable MRD status, and up to 2 years of treatment before of combined treatment before discontinuing zanubrutinib and venetoclax. And here you see that the progression-free survival at 36 months was basically the same in patients with or without TP53 aberration. So moving to our clinical case discussion, we would like to apply the evidence derived from these studies to our everyday clinical practice. And so I would like to start by discussing with you, Nicole, David, who is a 63-year-old man with symptomatic CLL, now because of enlarging lymph nodes, fatigue, weight loss, and increased lymphocyte count, right stage 3. And by biomarker profile, we identified the presence of unmutated immunoglobulin genes, but no TP53 aberration. He has a good renal function, no relevant comorbidities, and a performance status that is mildly impaired, probably mostly because of the underlying progressive disease. So, what option would you discuss, Nicole, with David? What would you favor?
Yeah, I mean, I would absolutely. I mean, David's young. He's unmutated, but he doesn't have a deletion 17p or p53. He has good organ function, and so we would absolutely favor a time limited approach for him. Easily I can see an oral combination for him. In the U.S. we would use probably a second generation, so like a calibrutinib venetoclax. Although to be fair, remember, we're also waiting. It is on the NCCN guidelines, as Lydia pointed out, but we're still awaiting our official FDA approval. But that's what if not, we would do venetoclax obinutuzumab. I think that's equally fair as well, particularly extrapolating, of course, given the data that we just showed before with CLL 17, that even the unmutated, I think it was fairly even. So we certainly would do a time limited approach for this gentleman.
Okay, so thank you so much, Nicole. I just want to discuss with you, because probably in US it happens more frequently. What if David comes to your office and says he wanted the deepest possible remission? Would you still prescribe acalabrutinib plus venetoclax or venetoclax plus obinutuzumab? Any other options you would consider?
Yeah, I mean, I think this is great. This leads up to a discussion about whether or not we would add a triplet to, do a triplet regimen with him. I think there's still very good data for him getting a BTK venetoclax doublet versus a triplet. But I think it brings up the fact that we do need more follow-up regarding triplets, and we can talk about where we think triplets might be best. And certainly there are patients who do achieve undetectable MRD getting a doublet. So I think we would still prefer a doublet. We have to weigh the risk benefit, I think, of toxicity as well.
Thank you. I would totally agree. I see there is a particular benefit of AVO in patients carrying unmutated immunoglobulin genes, but still it comes at a price, as we discussed, in terms of risk of infection. So it should be carefully considered. So let's move to a different scenario. In this scenario, David is 70-year-old, and again, he has developed a symptomatic disease requiring treatment because of enlarged lymph node, fatigue, and weight loss, an ASC count of 78,000 per microliter. But this time, when we perform the biomarker profile, we do not only find unmutated immunoglobulin genes, but also that the CLL cells are carrying both 17p deletion and TP53 mutation. Again, no relevant comorbidities, good renal function, a reasonably preserved performance status. What option would you discuss with this patient, Nicole?
Yeah, so this is our high risk patient, right? So we, if he's fit, of course, there's always the option of chronic continuous therapy, because we have in a sense, the longest data on patients in this subgroup that are considered high risk, and the PFS is very good. But, I do think that, let's say he really preferred a time limited option, then we start thinking about, well, is this somebody who might be fit based on some of the data in high risk individuals for a triplet combination? And so I think that, you have to discuss this data, with him as well, to see if this is something that, when we consider, even despite the data that I showed with the randomized data from AVO that didn't include 17p or p53, but then we showed some, there's some data obviously in high risk individuals. And so this is where this might be a good fit, depending upon if the patient is willing to take on some additional toxicity. So this is where I would consider a triplet as well. So I would offer either chronic continuous or either an MRD guided approach or a triplet approach, because of the high risk features. If they wanted something that's time limited, that's where I would bring in either MRD guided or a triplet if they wanted a time limited approach. Otherwise, I think chronic continuous is also okay.
Yeah, that's a great point. I dare say that probably we still miss some information in terms of sequencing, like, for example, the progression-free survival too. So patients relapsing after fixed duration, even if they carry higher risk disease, may still remain in remission for a long time upon retreatment. And my main concern with continuous BTK inhibitor treatment is, of course, the risk of developing resistance. And at that point, of course, you cannot reuse the same class of drugs. You have to change your treatment strategy, and this is something of concern, I would say, in the disease trajectory. What about the use of MRD-guided doublet or triplet? You already mentioned, Nicole, that actually is something you would consider, and I'd say we should probably collect additional data in this regard, especially in the higher risk subpopulation, because they were not included, for example, in the FLAIR trial because of the randomization to FCR. So, but it's still a subgroup of patients where I feel we need to improve our treatment strategy in order to achieve long-lasting disease control. And Nicole, do you want to share with us some data in terms of MRD results in this and other subgroup of patients?
So from CLL 17, we talking about the fixed duration combinations. Patients can achieve a deep MRD negative remissions here with either venetoclax obinutuzumab or venetoclax ibrutinib compared to chronic continuous therapy with the BTK inhibitors. And so this is, again, more evidence that when we talk about patients trying to get time-limited approach and get off therapies, they can achieve undetectable MRD, and then if later on, hopefully get a long time period off of therapy, and you can recycle therapies if they achieve a long remission duration or response duration to these treatments. And so that's an advantage of the time-limited therapies. Now, with regards to the triplets, here's the combination with acalabrutinib, venetoclax, and obinutuzumab from Amplify. And again, you can see here that clearly the triplet combination, high levels of undetectable MRD with a time-limited approach. Obviously, there's also high undetectable MRD with chemoimmunotherapy, and we knew this. This is not new data, but certainly we've moved away from chemoimmunotherapy, but we would expect this compared to, let's say, chronic continuous therapy. You could see here less durable undetectable MRD with the AV combination as compared to the triplet. Now, what about, obviously, there's this concern that even though we saw these great results in Amplify, particularly for unmutated patients with AVL, what about the additional toxicity? We know that there's the potential of additional toxicity with a triplet combination as compared to a doublet. And this was a study that was presented looking at whether or not patients were started with obinutuzumab early on, as we've been seeing given in the AVO combination, or if they introduced obinutuzumab much later in the combination with AV starting first and then adding obinutuzumab much later at cycle 15 and on. And you can see here that with the adding obinutuzumab much later, there was a lot less toxicity with regards to neutropenia and grade 3 or more infectious complications when you add obinutuzumab later on. And then they were still able to have similar efficacy with regards to undetectable MRD, despite adding obinutuzumab later on. Now, obviously, we'd like to see more follow-up and more data with this study, but I think it's encouraging to say that there's probably more than one way to give these combinations, and we can think about that with guidance to older, frailer patients if you're considering a triplet combination.
Okay, so if we want to summarize what we learned from these very interesting clinical scenarios, in our first patient, a young, fit patient with symptomatic CLL, who wants to prioritize efficacy but minimize the time spent in the clinic and the treatment burden. In this patient, we have a strong case for the use of a fixed duration combination of a BTK inhibitor plus venetoclax. If we want to achieve the deepest remission possible, we can consider adding the anti-CD20 monoclonal antibody obinutuzumab, so using a triplet instead, taking into account the increased risk of some adverse events like infections. In patients who are older and are carrying higher risk disease, including TP53 aberration, on one side, of course, we want to achieve long-term disease control, and on the other side, we want to decrease the toxicity burden. So probably based on the data we have available, it would be worth considering to apply an MRD-guided approach, taking into consideration that so far we have only limited data in phase 2 trial in the highest risk subgroup of those carrying TP53 aberration. And we can consider also the addition of obinutuzumab, especially to the combination of acalabrutinib plus venetoclax based on the encouraging results of the ADO trial, and define strategies upfront in order to address toxicity. I dare say in every clinical case we discussed, no room for chemoimmunotherapy anymore, nor in US or in Europe. Would you agree on that, Nicole?
Absolutely would agree on that. I think there would have to be rare exceptions to reintroduce chemoimmunotherapy in light of all the data that have emerged in the last 10 years.
So thank you so much for staying with us, and thank you so much, Nicole, for the fruitful discussion. It was my great pleasure.
No, always a pleasure, Lydia. And again, great options for patients with CLL, and hopefully we'll have more data in the future figuring out how to transition some of these therapies, including in patients with high risk, but certainly a pleasure. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/WBT860.